The Oregon Health Authority has recently published its annual data report for 2021, making 24 years of data available for over 2,000 adults who have died under the Death with Dignity Act. The Oregon 2021 report reveals several concerning trends. Firstly, an exponential increase in the number of assisted suicide prescriptions and deaths. On average, the number of assisted suicide prescriptions increases 13.6% annually, and the number of assisted deaths by 14.7%. This is over an 1,000% increase in both measures since its legalization in 1998. Secondly, assisted suicide participants in Oregon are disproportionately covered by government-sponsored insurance in comparison to national averages. In 2021, the vast majority of participants, 79%, had only government insurance, Medicare or Medicaid. There is also an upward trend in the number of participants who are concerned about the financial implications of care. In 2021, 1 in 11 participants had this concern. Being a burden on caregivers and loved ones continues to be a significant concern of participants. In 2021, over one-half of those who died by assisted suicide felt like a burden on their caregivers and loved ones. The report also reveals an expansion of patient eligibility to include typically non-terminal and treatable psychological illnesses. Most notably, in 2021, patients were eligible for assisted suicide because of anorexia for the first time. This is particularly concerning as the number of patients referred for psychiatric evaluation continues to decrease. In 2021, less than 1% of participants were referred for psychiatric evaluation. Lastly, the report reveals systemic failures in detecting coercion and abuse. Many doctors who prescribe assisted suicide drugs have little or no relationship to the patient prior to the assisted suicide consultation. In 2021, one doctor wrote 47 prescriptions in just 1 year. Changes in the law only exacerbate this issue. In 2021, 20% of participants were exempted from the 15-day waiting period, and out-of-state participation is now allowed. There are also significant data limitations. There is no independent pre-evaluation or post-mortem review of assisted suicide cases, and rejected assisted suicide requests are not documented. All of the data relies on the prescribing doctor. Data is also destroyed after 1 year, making retrospective research impossible. In summary, there is a false sense of confidence in Oregon's assisted suicide safeguards. Today, assisted suicide is an increasingly attractive option for patients who are looking for a fast and affordable end-of-life option which does not place burden or financial strain on others.